Good afternoon, good evening, I would say, to everyone. First of all, happy birthday. I'm really happy it's not my 75th birthday, but all the best to you. Okay, I was asked to talk about evidence-based medicine and clinical research. Both are needed, neither is perfect. Some of you, because some of you are my really good friends, so some of you know that I really like evidence-based medicine, and it's really hard to imagine healthcare system nowadays without evidence-based medicine. And here are the components of evidence-based medicine. So it's an integration of few elements like clinical expertise, scientific evidence, and patient's values. All three are needed in order that we are able to say we are practicing evidence-based medicine. People may ask, why do we need evidence-based medicine? And there are many reasons for that, but I will just mention two of them. Kill as few patients as possible. I think that I do not have to explain it, but this is really the important reason why we need evidence-based medicine, why we need evidence, updated evidence for taking care of patients. Why evidence-based medicine? Because all of us are suffering of information overload. And an important question is how to keep up with the scientific literature. And some people are saying it's mission impossible. And in a way, evidence-based medicine helps us to deal with the scientific literature. On this slide, I summarize steps for practicing evidence-based medicine. Everything starts with a formulation of an answerable question. So it's the famous acronym PICO, which includes all these four elements of any clinical question: population, intervention, comparison, and outcome. The second step, once we define what question we want to answer, is finding the best evidence. The third one is critical appraisal of the evidence. The fact that something has been published doesn't mean that it is of high quality. So this third stage is extremely important. And the final is applying the evidence to the treatment of patients. One of the principles of evidence-based medicine say that there is a hierarchy of evidence. So all trials are equal, but some trials are more equal when we want to make some decisions. And here, what is presented here is a hierarchy of evidence for questions about the therapeutic intervention or prophylactic intervention. At the top of this pyramid are randomized controlled trials, systematic reviews, and meta-analysis with the lowest risk of bias. Even if some people are criticizing it, I will come back to it. Since the beginning, there was some criticism when it comes to evidence-based medicine, and accusations such that this is a cookbook medicine. There were accusations that it denigrates clinical expertise, that it ignores patients' value, were raised by critics of evidence-based medicine. John Ioannidis, who is a professor of epidemiology at Stanford University, quite recently stated, as evidence-based medicine became more influential, it was also hijacked to serve agendas different from what it originally aimed for. He also stated clinical evidence is becoming an industry advertisement tool. So very strong accusations. And many other people who are insiders or practicing evidence-based medicine are also criticizing it. Evidence-based medicine is broken. Evidence-based medicine, a movement in crisis, with a question mark, but still. Care for a particular patient may not match with the best average evidence seems to suggest. And the criticism of EBM is also that EBM has neglected the humanistic and personal aspects of medical care and moved the focus away from the individual. So in my first summary for this part of presentation is that I think we all agree that ABM is needed, but it's not perfect. On the other hand, as Mary Fran said, I don't think perfect is interesting. I think what makes life exciting is the imperfections. So let me move on now to something which I already mentioned is really very much linked to evidence-based medicine, and these are randomized control trials, systematic review, and especially meta-analysis, which are very much criticized, especially meta-analysis. But I already showed you that the strongest evidence comes from randomized control trials and meta-analysis. In this audience, I don't have to explain what are randomized control trials, and I think that most of you agree that large, well-designed, and well-implemented randomized control trials are considered the gold standard for evaluating the efficacy of healthcare interventions. But people are criticizing randomized control trial, like the question, do you know about any randomized control trials that provide evidence that we should use randomized control trials? And probably we don't have it. There are many limitations of randomized control trials, internal validity, and of course there are also limitations coming from external validity, such as setting. What works in one country, in one setting, may not work in another. Characteristics of the patients. There are studies which include better prognosis and exclude, and this comes from the real study, women, children, the elderly, and common medical conditions. So there's hardly anything left. Study procedures. Patients may receive treatment or care which are difficult to achieve in the real world. Outcome measure, randomized control trial, may use composite measure infrequently used in clinical practice. This is simply because it's much easier to do to calculate the sample size and to perform the study as well. Incomplete reporting of adverse effects, and last but not least is, of course, cost. So there are many limitations of external validity and internal, which I did not discuss in detail. Many of us here in this audience are interested in pediatric nutrition, and there are many limitations of randomized control trials in pediatric nutrition. And for example, critically relevant outcomes related to nutritional practices may take years to become apparent, and it's therefore difficult to design and implement randomized control trials that last for sufficient time to cover more than just a small fraction of the process leading to the final outcome. And it's very much different, for example, to pharmaceutical trials. Diet nutritional exposures are complex and interrelated, and in most cases, short-term effects do not persist in the medium to long term. And most studies assess responsive to single macro or micronutrient changes which may not reflect real-life conditions. And there are probably many other limitations to randomized control trials also in pediatric nutrition. And there are also problems with systematic reviews and meta-analysis. And first of all, let me explain that these two terms are being used interchangeably. However, they do not mean exactly the same. Systematic review is a review of clearly formulated clinical questions which uses clear, explicit method to identify, to collect, to analyze data, in this case randomized control trial. But eventually you end up with analyzing each randomized control trial separately, which may be at the meeting like this one quite boring when you start to present 10 trials or something like that. Meta-analysis is when you use statistical techniques to pull the results of all randomized control trials which were identified. And of course, it's much more appealing to the audience to present just one result. But there are many criticisms of meta-analysis. One of them, some of them are presented here: mixing apples and oranges, mega silliness, meta-analysis, statistical alchemy. And I can feel that some of you do agree with what is on this slide. John Ioannidis, who I already quoted, mentioned that the production of systematic reviews has reached epidemic proportions. Possibly most systematic reviews are unnecessary, misleading, and conflicting. Please remember about this difference between systematic reviews and meta-analysis. For some topics, there are more systematic reviews than individual trials included in these reviews. And as a matter of fact, when you look at some of the topics, you will find really a number of meta-analyses. Hans, who is was the next, one of the next speakers, together with his young colleague from his department, they look at the data on probiotics, on prevention of necrotizing enterocolitis. And if you look at this recent data, you will see that just in 2 years, there is 14 different meta-analyses on probiotics for preterm infants. And still, despite all this data, there are no recommendations which probiotic to use and which not to use. What are the possible flows in a meta-analysis? Not in a systematic review, but in a not only in systematic, but especially in meta-analysis. I summarize some of them here. Failure to identify all relevant studies. So that's why searching one database is never enough. Risk of bias in the included trials. Please remember, any meta-analysis is only as good as the constituent studies. If they are of bad quality, of methodological quality, you cannot improve them by performing meta-analysis. Exclusion of unpublished data. We know that unpublished data differ very often from published data. And believe me, it's not very easy to identify published data. To identify unpublished data is even more difficult, but still, inclusion of unpublished data reduces the risk of publication bias. Something that many of you do not like, I don't like it as well, it's the opposite conclusions, but if you look into the detail, you will see there are usually differences in review questions, search strategy, etc. And finally, something which is more frustrating, which are inconclusiveness. So statements such as no clear evidence or further research is needed. So there are many things that are linked and many limitations of a meta-analysis that all of us are aware. So one may think, stop performing meta-analysis is probably the question I should ask myself, because I have done a number of meta-analyses. So perhaps I should think about it. But if you look at the literature, you will see that people representing, for example, Cochrane collaboration in the UK, like Mike Clark, who published this paper in this article commentary in The Lancet a few years ago and in the PLOS Medicine, nobody should do a trial without reviewing what is known. Clinicians should begin and end with systematic reviews of relevant evidence. So despite this criticism, there is a need to do these systematic reviews. Let me go back again to this slide, which I already showed you. What are the components of evidence-based medicine? Once again, clinical expertise, patient's value, and scientific evidence. And something which is very much often questioned is this scientific evidence. People are asking, can we trust clinical research? And again, let me quote some famous or so important people or figures in medicine. Marcia Angel, it's simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physician or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as editor of the New England Journal of Medicine. So it's really something who is like an insider of the scientific literature. Richard Horton, who is editor-in-chief of The Lancet, very recently stated, the case against science is straightforward. Much of the scientific literature, perhaps half, may simply be untrue. And John Ioannidis, he published this paper already a few years ago, most published research findings are probably false. And he also summarized when research findings are less likely to be true. So, for example, when you look at the sample size, when the conducted studies are smaller, they're less likely to be true. Effect size, when effect sizes are smaller. Analysis, where there's a greater number of and lesser preselection of tested relationship. You are looking for such a long time, eventually you will find something, like fishing for significant effects. Flexibility in research design, where there is greater flexibility in designs, definition, outcomes, and analytical method. This is one of the reasons why it's so important to publish the protocol of your study, because then this possibility for manipulation is much smaller. Conflict of interest, when there is greater financial and other interest, then of course there is, it's less likely that the research findings will be true. And finally, hotness of the research field. I'm very much interested in probiotics, in microbiota. If you look at the literature, only last year there were more than 6,000 publications, because this field is really is of interest of many of us. So this is a summary when research findings are less likely to be true. But still, if you look at the evidence, again, this comes from the Lancet, no critic ever suggested that reliable evidence should not be a key to effective problem solving and decision making, despite all this criticism. So my summary number 2 is clinical evidence research is needed, but it's not perfect. On the other hand, as George Bernard Shaw stated, if there was nothing wrong in the world, there wouldn't be anything for us to do. So there is a lot for us to do. And what can be done to solve problems with EBM and clinical evidence and research? And I will just show you some of the initiatives, some of the activities which are taking place. So let me start with what can be done to solve problems with EBM. So this is EBM, the Evidence Manifesto. It's like the main message is time to fix the E in the evidence-based medicine. And it's a response to systematic bias, wastage, error, and fraud relevant to patient care. And some data are saying that 80% of health research is wasted. And why 85% of health research is wasted? The reasons are that because 50% of it because it never gets published, of the remaining another 50% because publication is not complete and applicable, and of the remaining another 50% because the study includes fixable design flows and lacks systematic review of literature. So despite this all criticism, look how important it is to perform systematic review if you are doing any research. Going back to the Evidence Manifesto, I will not go through all of these elements because you can read it in British Medical Journal, but just allow me to mention some of them. So they suggest expand the role of patient, health professionals, and policymakers in research, increase the systematic use of existing evidence, because then we do not repeat the studies which have already been done, something which has been already documented. There is no need to repeat it again and again. Produce better usable clinical guidelines. I think that all of us agree that there are too many guidelines, and probably we have to do something with that. And finally, if you have other ideas, anyone can contribute with suggestions through the online form. So I really, because I presume many of us are really becoming the critics of EBM, that everyone can contribute how we can solve problems with evidence-based medicine. What can be done to improve evidence or clinical research? Again, there are many initiatives, like many organizations develop standards for conducting research, including pediatric research. It was published a few years ago in Pediatrics. Standards for reporting clinical research. This is something which I am enthusiastic also, and I really like it, and I promote it everywhere where it's possible. Equator, this is a website which I always encourage everyone to remember. Reporting guidelines, it is a website of reporting guidelines which provides structured advice on what information needs to be included in an article as a minimum requirement to allow readers to assess the study methodology, its relevance, and the validity. And probably many of you are quite well aware of consort statement for reporting the results of randomized control trial, or STROBE for observational trials. But please have know that there are many, I think that at the moment, more than 300 various guidelines for many study types. So you can look at those, but these are probably the most important. Another initiative that you may be aware, all trials, and this is the person behind it. All trials registered, all results reported. And it's really extremely important that all trials, past and present, should be registered, and the full methods and the results reported. And they are really now making an effort that the results of the study should be publicly available within 1 year after the completion of the study. And I think it's really extremely important initiative, first of all, that we are aware of the studies because they are registered, and then as soon as possible that the results of the studies become publicly available. Another initiative which I really support very much, and also within our societies, there is a working group on outcomes in nutritional trials. Nowadays, in the future, it will be probably not only in nutritional trials. It's very similar to this initiative, COMET Initiative. COMET stands for Core Outcome Measure in Effectiveness Trials, and COMET brings together people interested in the development application of agreed standardized set of outcomes. They call it Core Outcome Sets. And what it is, it's an agreed standardized set of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of health or healthcare. This will allow us to compare various studies, and if the same definitions of outcomes will be used, it will be much easier to perform a reliable systematic review, reliable meta-analysis. I will just give you an example, duration of diarrhea. If I ask here people in the audience, for each one of us, the end of diarrhea means something different. It may be the last loose stool or might be the first normal stool. And might be 24 hours difference between those two. So this is really important. So my summary number 3 is strategies for the development of high-quality evidence have been developed. However, when you aim for perfection, you discover it's a moving target. And indeed, it is a moving target. However, there are many initiatives, again, which are trying to also to address this problem. And I just want to show you what is some recent publication. New England Journal of Medicine in 2017, last year, published a series of articles addressing the changing phase of clinical trials. And I would just show you, for example, they discuss, they provided and they discuss in full detail examples of new trial designs, such as adaptive design, which allow altering basic features of an ongoing trial in a predefined way. Pragmatic trials, so they are much closer to what is done in a day-to-day care. Basket trials, non-inferiority trials, trials in health insurance system. It's not that all of these trial designs were not completely unknown before, but they are definitely become more and more popular nowadays. And there are other issues that were discussed in this series. And finally, big data and real-world data. I will not discuss it in detail, but I think this is really coming. This is coming because we have a lot of this electronically collected data. I will just comment it with this slide. Please wait here until you are useful. And I think we still need information that this kind of information is really useful, and we're probably at the beginning, but it's unavoidable. So my concluded remark, as audience is likely to remember only 3 things from each presentation or speech. So here are my 3 concluding messages. Over the past 25 years, EBM has reshaped medical practice. EBM, however, is not perfect, and the concept is evolving in response to its critics. Much of clinical research is poorly designed, conducted, analyzed, and/or reported. However, strategies for the development of high-quality research have been developed, and if strictly adhered to by all stakeholders, this should lead to more valid and trustworthy findings. And finally, considering that new ways of obtaining healthy data will continue to emerge, the world of evidence-based medicine and clinical research is likely to change, and the ultimate goal, however, will remain the same, which is improving health outcomes. And let me finish with a final quote on perfection, and my final quote is, and it comes from Salvador Dali, "Have no fear of perfection, you will never reach it." Thank you very much for your attention.